Good morning, good afternoon, and good evening to all of you out there attending today's webinar on advocacy for palliative care and universal health coverage. I am Dr. Stephen Connor, the Executive Director of WHPCA, Worldwide Hospice Palliative Care Alliance, an alliance of over 450 organizational members in over 100 countries. And we're very pleased to have you with us today. We're going to be doing a series of presentations, and we're going to have about 15 minutes at the end or so for questions and answers. And so with that, let's just get rolling. I'm doing a short introduction, and we'll hand over to my colleague, our advocacy officer, Dr. Helena Davies. And then we're going to join a segment after that on children's palliative care before going to the questions and answers. So with that, let me start. So we're going to cover, as I said, palliative care, sort of the global picture of palliative care, and what do we mean when we say universal health coverage, and where does it all come from? Helena will give a walkthrough of all the content in this new guide, and I hope you've all been able to download the guide prior to the session. It's easily downloadable from our resources on the website. And then, as I said, Alex will talk about the special issues for universal health coverage for children. So there are 17 sustainable development goals that the UN established to help improve life on planet Earth. We have a big focus on the third goal, which is good health and well-being, because it's where universal health coverage sits in the big scheme of things. Universal health coverage goal was to achieve all countries achieving universal health coverage without financial burden prior to or by 2030. It doesn't look like the world is on track to meet that goal, but at that point there will probably be new goals set. But in addition to the health goal, we also think palliative care helps support a number of other significant goals, including the first goal, which is no poverty. We think poverty reduction and that palliative care helps reduce poverty because of ensuring patients don't get non-beneficial treatment that ends up bankrupting families. We also have a big role to play in education for health professionals. We know that most caregivers are women or girls, and so we try to help in supporting caregivers and try to achieve a bit more gender equality. Many times when palliative care is provided, families are able to go back to work. Sometimes patients are able to even work because of good symptom management and good care. So that's decent work. And then generally, we did a couple of years ago, the theme for World Day was about reducing inequalities. And certainly there are huge inequalities in access to palliative care that we know about. So moving on to what is UHC and the Sustainable Development Goals. The goal 3 has a number of targets, one of which is achieving universal health coverage, and in such a way that it doesn't cause financial hardships for families and patients. So there has to be financial risk protection built into universal health coverage. Also, there should be access to quality essential health services, safely, efficiently, effectively, quality services, medicines, and all essential medicines for all. We were fortunate to be successful in getting palliative care included in the continuum of universal health coverage, which goes from promotion to prevention to treatment, to rehabilitation, and then palliative, and recently long-term care was added to that continuum of care. But basically, if you don't have palliative care, you don't have universal health coverage. So we were really fortunate that due to advocacy efforts of the palliative care community globally, we were able to get palliative care included in that continuum. It's a real important win. So WHO does try to track what percentages of the populations in different parts of the world are accessing health services. universal health coverage services. And as you can see, the darker colors are the ones that have 80 or plus percent access to services. And you see the biggest gaps currently are in the Middle East and mainly in Africa and some parts of Southeast Asia. So there's still a long way to go to making that whole picture dark blue. In terms of the status of palliative care globally, we are in official relations with the World Health Organization, and we publish jointly with them the Global Atlas of Palliative Care, which kind of paints a picture of all palliative care globally. And so some of the data that we'll share with you comes from that atlas. If you haven't seen the atlas or you don't have it, you should download it from our website. It's a very valuable advocacy tool. So in the atlas from 2020, we used data from 2019, and the estimate using Lancet Commission methodology was over 57 million people, about 57 million people needing palliative care. We have about 1 million people who die every year, a million people a week die. That's 54 million deaths were recorded in 2019. And about half of those are estimated to need palliative care, though that could be a conservative estimate. And this is before COVID arrived, which pushed the numbers up to more like 60 million deaths, because certainly many of the people who were dying of COVID needed palliative care services. Most people living in low and middle income countries, most are older, but we also have children, and Alex will be talking about that a little later. Lots of people of those 25 or so million dying in pain because they don't have access to strong opioids for management of moderate to severe pain. And with all the deaths, we estimate that, around 100 million people grieving each year. And there's an average of about 16 people who attend a memorial service or funeral each year, or for each death. And if you add all that up, that's approximately 1 billion people attending services. So back in 2011, when we published the first atlas, we had estimated, based on the surveys of members around the world, that there were about 16,000 palliative care services caring for about 3 million patients. 6 years later, in 2017, when we redid the mapping of palliative care development globally, that number had increased to approximately 25,000 services serving around 7 million people. So that is some progress, but that's only about 12% of the need if you're looking at around 60 million people needing palliative care. So, and that need for palliative care is going to continue to increase each year as the population ages. Most countries, you'll see the darker colors are countries where there is integration of palliative care into the healthcare system. We measure 6 levels of development, from countries where there's no palliative care and we can't find people even interested in starting palliative care, to countries that are beginning to prepare that there are people interested and they're starting to develop palliative care services, but they haven't actually begun serving patients. The third level is bifurcated into preliminary isolated provision, and then generalized provision. And then the fourth level is bifurcated into beginning to integrate into the healthcare system and more advanced levels of integration. So about 2/3 almost of countries have either no or very limited delivery of palliative care. And only about 30 countries, 15% of the total, have good integration into the healthcare system. Paulina is going to be talking more about this model, the new model for palliative care development, and the 14 indicators for palliative care. But this is replacing the old triangular model that we had, the public health model for palliative care development from WHO, and a much more detailed approach to planning and implementing services. I want to just mention that this year, the theme for World Hospice and Palliative Care Day is compassionate communities together for palliative care. There are a number of significant movements, if you will, to expand the concept of compassionate communities globally, and in particular, the the one run by Public Health and Palliative Care International, that's dedicated to compassionate communities that support people with serious illness, their families, and those families after the death while they're grieving. That the purpose of those communities is to help support. And so it's a match made in heaven, if you will, between palliative care and the compassionate communities movement. And we're encouraging everyone to have events in your home countries to celebrate World Day this year. All right, so please do feel free to introduce yourself in the chat, but do put your questions in the Q&A box. Again, we'll have about 15 minutes at the end for that. We're going to end at the top of the hour. Please contact us by email if you need help in advocating for palliative care, in inclusion of palliative care and universal health coverage in your country. And thank you very much for joining us today. I'm now going to hand over to my colleague, Dr. Helena Davies, who will be doing the next presentation. You'll bear with us for a minute. There we are. Hi, Dr. Davies.
Hi.
Well, you might want to introduce yourself while I get your slides up.
I'm Helena Davies, and I'm the Advocacy Officer for the WHPCA. And this guide is an effort that has been put together by myself and another member of the team at the WHPCA, Tim, who is the project officer. And what the whole purpose of the guide is to provide an advocacy guide for palliative care to assist you in advocating at a national, regional or local level by using universal health coverage for leverage. And next slide, please. The guide consists of 6 sections. I'm not going to talk much more about palliative care because Stephen's covered that. I mean, I am going to obviously talk about palliative care, but I'm not going to talk about definitions of palliative care and the figures around palliative care because we've already covered that. I am going to talk in a bit more detail about universal health coverage, which is covered in section 3 of the guide. And I'm then going to talk about a number of aspects which are important to support advocacy using the principles of UHC, including the 2019 political declaration, but also the Lancet essential services model, the WHO model, the role of NCDs and primary healthcare, and I'm going to touch on the role of COVID before ending with the summary of what we've called the call to action, which is where you start if you want to use this guide as a mechanism for advocating. And we're really hoping that this guide will serve as a very practical tool that you can use. You're more than welcome to copy bits directly from it and to ask us for help and advice if you're unable to make sense of any bit of it. Next slide, please. But perhaps it's worth thinking initially about what we actually mean by advocacy. There are, of course, out there thousands of definitions of advocacy, but this is a particularly good one for our particular situation, which is about advocacy for health policy. And I'm grateful to Pettis, and it's actually Dilema, I apologise for my spelling mistake, who put this definition together, and it's available on the IAHPC website. But the advocacy for health policy is defined as the processes by which the action of individuals or groups attempt to bring about social and/or organisational change on behalf of a particular health goal, programme, interest or population. And I think very importantly, health advocacy includes educating policymakers and the public about evidence-based policy. There is an evidence-based building up around palliative care, and it's really important that we use that. And I think the other issue that's really important, and speaking as someone with lived experience of palliative care, I feel particularly strongly about this, is that palliative care advocacy is strongest when it includes the voices of direct stakeholders. So those who actually deliver and receive essential services and can testify and witness to the vast unmet need for palliative care that Stephen's already told us about. Next slide, please. So central to what I'm going to talk about is palliative care advocacy. Highlighted in red are the facts, as we've already learned, that it's an essential component of UHC. And that's why using UHC as a lever is such a potentially useful way of advocating for palliative care. And I'm going to also talk about the way that you can use the 2019 political declaration on UHC to help you advocate. But then I'm going to cover the Lancet Commission essential package that I've already alluded to, the fact that we need a sustainable workforce, a bit about primary health care, something about the economics of palliative care and the NCD epidemic. And obviously we are talking all the time about a range of health services for adults and children. And although Alex is going to talk specifically about children, everything that I'm saying is equally applicable to palliative care for children as it is to adults. And I'm going to just touch on COVID-19. Next slide, please. So what do we mean by universal health coverage? Well, we've already seen this definition, but I think the important things to pull out for this is that it's about need without suffering financial hardship. As Stephen already alluded to, many families, when they have palliative care, when they don't have palliative care, sell up their whole house if necessary to pay for care, which may be futile. And when they have the benefit of palliative care, there's evidence developing that palliative care is actually financially beneficial. It also is important to remember that it includes the full spectrum of essential quality health services. And because the full spectrum of quality health services includes palliative care, then you can't have UHC without palliative care, as we've already heard. And I think that's a really important message to take away from today, and a really important message to be conveying to your policymakers. If you don't have palliative care, you don't have UHC. Next slide, please. UHC consists of three dimensions: a service and population dimension and a financial protection dimension. But most country commitments really focus on service and population coverage, and there's very little focus on financial protection. So as you'll see, over 80% of the country commitments tends to focus on service and population coverage, and only 13% on considering financial protection. And what this basically means is there's systematic under-prioritization and underinvestment in reducing financial barriers to healthcare. And this is something that we really need to work hard to address with our policymakers. And we really need to work hard to get palliative care funded and to justify its funding to palliative policymakers. Next slide, please. So we've said that already that palliative care is an essential component of UHC, and it may feel like we're repeating ourselves here, but I think it's such an important message, and millions are pushed into poverty because of outspending on healthcare. And the economics of care are beginning to demonstrate that it's cost effective. It allows carers back to work. It may allow actual patients back to work, as Stephen's already says. It reduces hospitalizations and it reduces futile treatment. Obviously, this is all in the context of not wanting to save money, but wanting to provide an improvement in quality of life. But it's a sad fact of life that policymakers are very driven by the financial realities of the care that we provide. And if we can demonstrate that palliative care is not a very expensive thing to provide, and indeed may be cost saving and certainly cost neutral, then I think that will help us to advocate for palliative care. And I think that's an argument that you need to make yourselves familiar with. Next slide, please. What this slide shows is how introducing palliative care can break the cycle of late diagnosis of life-limiting illnesses, causing high level of catastrophic costs. And, you know, I think one of the other areas that tends to be compromised in the context of not having palliative care is, as part of the cost savings, young people are often pulled out of education and training. And that's particularly the case for girls and young women. And this is why we need to be trying to close the gender gap. But we can get improved function, return to work, and reduce discrimination. And that's through patient-centered information and pain and symptom relief. Thank you. Next slide, please. I think it's very important that in our advocating for palliative care, that we advocate also for the Lancet Commission Essential Package on Palliative Care, which is from the Lancet Commission on Palliative Care and Pain Relief. And again, this is something that I would recommend that you have a look at if you're not familiar with it. It contains the inputs to safe and effective provision of essential palliative care and pain relief interventions. And it talks about alleviating both physical and psychological symptoms and gives guidance on the medicines and equipment that can be safely prescribed or administered in a primary care setting. The essential package must be part of a universal health coverage platform for palliative care and part of the drive to achieve the Sustainable Development Goals relevant to palliative care, which are SDG 3, as Stephen's already alluded, particularly 3.8. And, you know, we aspire to having them achieved by 2030. As we've already said, this is likely to be overambitious, but they're an important thing to continue working towards. It's estimated that the cost of the essential package in low and middle income countries is about $3 per capita. So it's not an expensive intervention, and that's without considering the potential cost savings of delivering palliative care itself. And it's also important to remember that health services have to be complemented by interventions for relief of social and spiritual suffering to preserve the dignity of patients and facilitate access to health interventions and prevent financial hardship and impoverishment. And it may be that some of the funding for the Lancet Commission Essential Package and for palliative care should come from social care funding sources as well as from healthcare sources. Next slide, please. The Lancet Commission Essential Package consists of medicines, medical equipment, and human resources. And the medicines is based on the WHO Essential Medicines List, which focuses on off-patent drugs, because obviously these are cheaper than drugs which still hold their patents. I think one of the things which is a huge source of controversy is the hugely variable access to morphine. Morphine, which is actually cheap and should be widely available, is very disproportionately available in some places compared to others. And for example, in Haiti, only 5 milligrams of morphine equivalent opioids are available per capita per year. And this is in comparison to 55,000 milligrams per capita in the US. So there's a huge disparity. And a lot of this is to do with fear of opioids and of misuse and crime associated with them, to so-called opiophobia. And this is a very important area to focus on. And as an absolute minimum, all essential packages should include access to immediate release morphine. And that's something which you really should be advocating hard for with your policymakers. Medical equipment, if you can't get everything right to start off with, then maybe just start off with adult diapers and an opioid lockbox, but the list is much longer than this. But in terms of human resources, all healthcare professionals need training in the essential package and in palliative care, either basic, intermediate or advanced. And it's estimated that the basic training is only about a week's equivalent of training, whereas the intermediate, you're looking at 1 to 2 months, and the advanced is for people who are really specialising in palliative care, and we'd expect to take 1 to 2 years to train. And we really need a sustainable, educated workforce, but importantly, based on competencies rather than job roles. So it's possible to train up community workers to deliver palliative care that is normally delivered by nursing staff, but by being very clear about what the competency required is and training them very specifically for a very niche role that is related specifically to palliative care. And I think that's one of the critical things, again, when you're advocating for palliative care, to emphasize the fact that you can use a community workforce and a primary care workforce, and it's not always necessary to use highly trained specialist healthcare workers to deliver palliative care. Next slide, please. And that brings us on to primary healthcare and the fact that the whole of society approach, which includes primary care, secondary care and tertiary care, and aims to achieve healthcare for communities and individuals as early as possible in the continuum from health promotion and prevention to treatment, rehabilitation and palliative care, is the way that we should be tackling advocacy for palliative care. The primary healthcare approach is different from that of primary care. Primary care is about delivery to a generalist home, often delivered by primary care workers and community workers, and referring upwards to more specialised services, secondary and tertiary care. And primary healthcare includes that whole continuum. It does, however, seek to provide care as close to the patient's environment as possible, and ideally palliative care is provided at home. Again, that's a potential cost saving rather than paying for expensive extended hospitalizations. And primary healthcare is integral to the effective delivery of UHC and therefore to the effective delivery of palliative care. And as the WHO have said, investments in quality primary healthcare will be the cornerstone for achieving UHC around the world. So next slide, please. Having talked about the Lancet Commission essential packages and about primary healthcare, we also have to consider the non-communicable diseases so-called epidemic. This is responsible for about 17 million deaths per year before the age of 70. And again, this is disproportionately focused in low income countries, with 86% of these NCD deaths occurring in LMIC. And an individual and global economic impact. We've talked about the individual impact in terms of pushing families into poverty and catastrophic expenditure. But there's also a global economic impact, and it's estimated that the NCD epidemic will be responsible for about a debt of about $7 trillion in the 2 decades between 2010 and 2030. Historically, there has tended to be a treatment focus as far as management of NCDs goes, and UHC should ensure appropriate control of NCDs. But access to palliative care is absolutely critical to control NCDs. And it's about the whole of illness trajectory. So getting palliative care in there early in the whole illness trajectory. And it's not just about the end of life, and it's not just about cancer, which is where palliative care has tended to be focused historically. And strategies for tackling NCDs are integral to palliative care advocacy. And this is about the whole kind leave no one behind philosophy. It's important to include those who are disadvantaged and disenfranchised, such as individuals with disability, refugees, women and girls, and many other disadvantaged groups. So next slide, please. None of this is possible, of course, without an efficient healthcare workforce. And unless you've got adequate numbers of appropriately trained individuals, you're not going to be able to be effective at implementing UHC, primary healthcare, or palliative care. And training in palliative care should be made available for all healthcare workers. But it's estimated that despite us trying to recruit increasing numbers of healthcare workers around the world, and particularly in LMICs, that there's likely to be a shortage of 18 million health workers by 2030. And this is going to become even more of an issue as the population ages and there's a greater need for healthcare. Next slide. We're returning here to the WHO palliative care house model that Stephen introduced you to earlier. And right at the centre of it are people with palliative care needs. And it emphasises the importance of the meaningful involvement of people with lived experience of palliative care by placing people with palliative care needs at the centre of the model, standing on a footprint of research, health policies, and empowered people and communities. And as Stephen's already alluded to, compassionate communities and the decade of ageing are highly relevant to empowered communities. Compassionate communities ensure that individuals other than those with the need for palliative care are involved in palliative care, and the decade of ageing highlights our ageing population and the increasing need for palliative care in relation to that. But obviously, as well as empowered communities, we also need the essential medicines and education and training to provide support that we've talked about, the Lancet Commission essential package, education and training of our healthcare workers, so that everybody is knowledgeable about palliative care and everybody is knowledgeable about UHC. And together they'll enable provision of integrated health services with palliative care at its core. Next slide, please. This brings us on to the 2019 Political Declaration on UHC, which was the first high-level meeting on UHC and which took place in September 2019. And it was an international commitment to achieve UHC, which was set out in a political declaration and adopted by member states on the 23rd of September 2019. And it aims to accelerate progress towards achieving UHC. And it reinforces the commitments taken in 2015 by UN member states towards attaining the health-related sustainable development goals. And returning again, it keeps popping up, but again, that emphasizes the importance of it. SDG target 3.8, aiming to achieve UHC by 2030, includes the implementation of palliative care as part of the continuum of essential healthcare services. And in the guide, next, we provide very specific guidance on how to use the political declaration. And it's very useful leverage if your country is a signatory, and the vast majority of countries are. And we signpost you to relevant paragraphs about right to health, NCDs and mental health, health services, disabilities, access to medicine, financial hardship, primary healthcare, and the health workforce, so that you can use those specific paragraphs to advocate as part of your UHC advocacy for palliative care. Next slide, please. Nothing would be complete, even now that we're supposedly out of our emergency status, without mentioning COVID-19, and it's still a very real problem. There's the acute need with numbers of people suffering with COVID disease who really raised the platform and bring to light the need for palliative care. And especially during the time of the pandemic, there were huge numbers of people suffering with serious health-related suffering related to COVID disease who needed palliative care and often did not have families or friends available to help them out because they were isolated because of their disease. Even as the acute need wanes, there's a chronic need with the prevalence and impact of long COVID on individuals and their families and carers. And the last estimate that I saw estimated that 10% of individuals who suffer from COVID will develop long COVID. And it's as yet unknown what the long-term trajectory of that is going to be and what the long-term effects will be. But it's certainly responsible for significant serious health-related suffering and is going to create an additional need for palliative care. And then there's the grief and bereavement need, which Stephen spoke about again in relation to the billion people attending funerals. But the families of those that die of COVID need close assessment and support. And certainly those who were bereaved during the pandemic seem to be at risk for prolonged grief disorder. And this is something that we need to be aware of and include in our thoughts about palliative care, which includes management of grief and bereavement as we move forward. Next slide, please. So this leads us on to our call to action. We've been through the main sections of the guide, and we're now sitting down trying to put together our advocacy argument. The first thing that we need to know before you actually put together your advocacy argument is what the current state of play is. Stephen's already spoken about the Global Atlas, which is not only an invaluable resource for learning about palliative care, but also will provide you with information about the prevalence of palliative care and the state of palliative care in your context. And you can find out whether or not your country, your context, is at the bottom level with no palliative care, at the top level of advanced integration of palliative care, or somewhere in between. And I think it's very important that you use the Global Atlas to try and establish where you are in terms of palliative care to start off with. And next slide, please. The other thing which Stephen alluded to, and this is a busy slide which is difficult to read, but I'll highlight it for you. This is the palliative care indicators that the WHO have put together. And again, I would recommend that you have a look at this document, which is available on the WHO website. If you put in palliative care indicators, it pulls the document up. And this is a way of scoring palliative care provision in broad areas related to the palliative care house of integrated palliative care services, health policies, use of essential medicine, education and training, empowerment of people and communities, and research. So you'll see how that relates to the pillars of the WHO house. And there's subsections in all of them and core and strategic scores depending on whether you're just starting out in palliative care or already have an established palliative care service. So between the Global Atlas and the palliative care indicators, you can get a very good idea of where you are in your own context in terms of palliative care provision before you start to put together your palliative care argument. But it's also important, next slide, to be clear about what your progress towards UHC is in your context. And there's two ways that you can do this as well. One is by looking at the tracking of the Universal Health Coverage Global Monitoring Report. And Stephen showed you some data from that earlier. And that will show you where your own context is or was in 2021 in terms of universal health coverage progress. But it's also the UHC 2030 website has a data portal which you can put your own country into and find out where it is in terms of UHC progress, which is pretty up to date. And I'd certainly recommend that if you're wanting to learn more about UHC, that you have a look at the UHC 2030 website, which is extremely informative and has a lot of data on UHC and is worth following their newsletter and be keeping up to date with what new developments are in UHC in relation to that. But both of these will provide information on how specific countries and areas are doing in terms of making progress towards UHC 2030, and very useful for determining how engaged your government and policymakers are in the UHC journey. Next slide, please. So having determined what the current state of play is in terms of using the Global Atlas and the palliative care indicators, and used the WHO data or the UHC 2030 data to determine progress towards UHC, you also want to determine what the understanding of palliative care is by policymakers and whether you have an educational job to do about palliative care before you begin to advocate in any other way. You need to know about the availability of the essential package, and it needs to go into your advocacy argument that you must have provision of the essential package as part of the palliative care package that is contained within UHC. It's very important that as you develop your advocacy argument, you involve people with lived experience of palliative care. So as you put together the argument, as you put together the policy document, get some people who've actually had lived experience of palliative care to read the documents, to share development of the advocacy argument with you, because in that way, it will really speak to the people and the policymakers. And it's often helpful to have case reports in your advocacy argument because it makes it into a living document for the policymakers. You need to be clear about what the workforce requirements would be to deliver the palliative care that you're asking for. And it may be that this is an example of progressive universalism, where you start small and gradually build up and develop your palliative care provision. You also need to know about whether your government is committed to the political declaration. And if it is, which it probably is, then use the political declaration to help in your advocacy argument. And this brings us right back, next slide please, to the beginning, to palliative care advocacy right in the centre of the circle, and it's recognising that it's an essential component of UHC, but also that you can use the UN high-level meeting political declaration on UHC to help with your advocacy argument as additional leverage, and that there are a number of things that you need to consider as you put together your palliative care advocacy argument, including the Lancet Commission for Essential Package, how much you need in terms of a sustainable and educated workforce, the importance of primary healthcare as a key provider, the economics of palliative care, and the relevance of the NCD epidemic, including mental health, and recognition that the whole range of health services needs to be provided for both adults and children. And finally, that you probably need to include in your argument the context of COVID-19 and how it is relevant to palliative care in your context. I really hope that you are able to use this guide as a practical tool. That's what it's been developed for. And there's lots of guidance within the document which expands on what I've said today. But I've walked you through the document and what's contained within it, and we'll be open to questions in a few minutes after we've heard from Alex.
Great. Thank you very much, Elena, for that excellent presentation. And we are going to be joining Alex Daniels as the education manager for International Children's Palliative Care Network, and Howard Kinua, who is actually the communications officer for both WHPCA and ICPCN. So we're going to join them in progress now. Thank you very much.